I'm Jordan Lormore. I'm a student physical therapist assistant from Jeff State. Today I'm going to be talking to you about lymphoma. So every single day, a person's body is creating new cells, old cells are dying, and dead cells are being excreted. When this process is interrupted by a mutated cell, it's known as cancer. And when the mutated cell is a lymphoid cell, it's known as lymphoma. So a lymphoma is a mutated lymph cell. And the lymph cell, it originates in the bone marrow where our stem cells are created, and then they either turn into myeloid cells or lymphoid cells. So we're looking at the lymphoid cells since we're talking about lymphoma. The lymphoid cell then turns into a lymphocyte, and the lymphocyte then matures into either a B cell, a T cell, or a natural killer cell. Lymphomas usually affect the B cells and the T cells. Mutated lymph cells are found in lymph tissue. They don't die as quickly as regular cells, so they continue to multiply and they don't die, and they end up pushing out all the other cells because there just isn't enough room for all the cells. And since the mutated cells won't die, you end up having a high count of the white blood cells and a low values for red blood cells, hematocrit, and hemoglobin. This is usually found with routine blood work, and it's typically followed by the finding of a painless enlarged lymph node. If an enlarged lymph node is detected, the doctor will take a biopsy of the lymph tissue. By examining the lymph tissue cells, the doctor can determine whether the patient has Hodgkin's or non-Hodgkin's lymphoma. Hodgkin's lymphoma is easily detectable because it has a large multinucleated Reed-Sternberg cell that is easily identifiable and easily treated. Non-Hodgkin's lymphoma is much more difficult to detect because the cell mutations are minuscule, and it usually requires a full body scan to detect. The full body scan allows the doctor to see the enlargement of the lymph nodes in comparison to the other organs inside of the person's body. In this picture, you'll be able to see the difference between the enlarged lymph nodes all over the person's body and then the normal sized lymph nodes, which aren't even detectable on the scan after the person undergoes chemotherapy. Once a person is diagnosed with lymphoma, the lymphoma is then staged using the Ann Arbor staging system. This stages lymphoma based on how many enlarged lymph nodes are detected, to what degree or size they are enlarged, and whether the perfusion is ipsilateral or contralateral, and also whether the lymph nodes are superior, inferior, or both in relationship to the diaphragm. So stage 1 would be one lymph node enlarged. Stage 2 would be 2 lymph nodes enlarged that are both superior or both inferior to the diaphragm. Stage 3 would be 3 lymph nodes enlarged above or below the diaphragm, and stage 4 would be 4 places where lymph nodes are enlarged superior and inferior to the diaphragm and ipsilateral and contralateral on the body. The symptoms that accompany lymphoma are referred to as the B symptoms. They include fever, night sweats, unintentional weight loss, shortness of breath, pain or pressure in the chest, a feeling of being very full after eating very little food, and then the enlarged lymph tissue, which is usually detected in the lymph nodes first. Okay, so risk factors with lymphoma, it's actually idiopathic, so they don't really know why lymphoma occurs, but there are some risk factors that seem to be across the board kind of similarities between people who do get lymphoma. And some of those are age. So with people 15 to 35, you're typically going to see more of a Hodgkin's diagnosis. And then people who are over the age of 55 is usually more often a non-Hodgkin's lymphoma diagnosis. Also, there's gender. Males do typically get lymphoma more than females, and then with race, whites usually get it more than blacks, and blacks more than Asians. And then there's also a risk factor with the environment. So if you do, there's been a link between woodworking or people who work around carcinogens that they're inhaling often. Typically, that just tends to be a risk factor. And then also the immunocompromised. So people with conditions such as HIV, they'll be more prone to getting the non-Hodgkin's form of lymphoma. And then there's also been a link between the Epstein-Barr virus and people who have had that are more at risk to get the Hodgkin's form of lymphoma. Then they're going to be given a prognosis based on the International Prognostic Index, which is made for lymphoma. And the things that you look at when you're giving someone a prognosis, or not us, but when the doctor's giving someone a prognosis, is going to be their age. Then they're also going to look at their Ann Arbor staging score, their hemoglobin levels, their lactate dehydrogenase levels, and then how many lymphocytes they had enlarged. So then for each of those items, they can get 1 point. So if they have a total of 5 points, then their risk is really high and their prognosis is really low. So if they only have 0 to 1 points on the risk factor index, then their prognosis is going to be really high and their risk is going to be really low. Treatment options for people with lymphoma include chemotherapy, radiation therapy, immunotherapy, stem cell therapy, target cell therapy, and then sometimes surgery. Patients who are going through lymphoma and treatment for lymphoma are likely going to have some impairments and limitations. Just from radiation and chemotherapy alone, you can assume that the person's going to have integumentary impairment because they're going to be losing their hair, so their skin is probably going to be more prone to shearing forces. Also, the musculoskeletal system can be impaired because of blockages in the lymph system can cause edema and likewise loss of range of motion at certain joints. And also the musculoskeletal system can be at risk because this person's already had most likely the unintentional weight loss because of lymphoma, and now they're on chemotherapy, which also causes weight loss. So you can assume that this person's strength and coordination is going to be severely decreased. As far as the neuromuscular system goes, there might be a swollen lymph node or gland that's pressing on a nerve, so you have to be aware that this person might have a loss of sensation or motor function. And then finally, for the cardiovascular and pulmonary system, swollen lymph tissue could be blocking either the passage of air, blood, or lymph fluid. And so these kinds of blockages can cause shortness of breath and edema accumulation, and these are things that we just are going to have to watch for and be aware of when we're working with patients with lymphoma. So what can we do as physical therapist assistants? We can help these patients maintain their strength and coordination that they now have by doing therapeutic exercises and therapeutic activities. We can help with edema accumulation by providing manual lymph drainage, range of motion, applying compression bandages, and we can encourage ambulation, which is so important, especially to help in the prevention of pneumonia. It's shown that patients who are undergoing high doses of chemotherapy are at a high risk for acquiring pneumonia, and it's also been shown that endurance training for 30 minutes at a time, 3 times a week, can severely decrease those odds of that patient getting pneumonia. And then we also can just focus on breathing techniques and just helping that patient to maintain their strength and functionality and to prevent any decrease in strength and functionality. Before diagnosis, these patients most likely experienced fever, night sweats, unintentional weight loss, shortness of breath, and then after their diagnosis, they went through their treatments, which most likely caused more weight loss, loss of strength, loss of endurance, possibly a loss of range of motion. By being cognizant of these factors as physical therapist assistants, we can plan and execute a safe and productive treatment plan for patients with lymphoma.